With a great pleasure, we welcome Dr. Khalid bin Thani. Dr. Khalid is a consultant cardiologist and head of medical department in Salmania Medical Complex. Dr. Khalid will take us through a journey to Dapagliflozin from treatment to prevention, as he will present the benefits of SGLT2 inhibitors generally, and of course Dapagliflozin specifically, in both diabetes and cardio aspects. Thank you so much, Dr. Khalid, and the floor is yours.
Assalamu alaikum. Good afternoon, everybody. I hope this topic will be a great topic. I tried to add a few things, the updated information from the guidelines regarding the heart failure. And today we're gonna focus on the SGLT2 Dapagliflozin benefits. These are my disclosures basically. So the definitions of heart failure that came across the European Society of Cardiology, and in regards to these different subtypes, we have the heart failure with reduced ejection fraction, and we have the heart failure with mid-range ejection fraction, and we have the heart failure with the reserve ejection fraction. So for the non-cardiologists, basically, these have been studied and been classified extensively according to the ejection fraction. Now we added also the heart failure with improved ejection fraction, where the patient will benefit from the treatment that's provided by the physicians, and then you have improvement in the ejection fraction basically. Now, all of us, we know that the heart failure with reduced ejection fraction, they are characterized by the frequent hospitalization, and these are linked to the higher mortality. So you can notice here that we always, during the hospital admissions, we count the 30 days mortality rate. As the patient gets more admitted, then the mortality rate gets higher. To get you the picture, how does this look like? If you compare heart failure with other really comorbid diseases, if you compare it with the breast cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, colon cancer, and rectal cancer, and the leukemia, you can see the magnitude of how bad is the heart failure in terms of 5-year death rates. So all of us, we know that the more you get admitted, basically, the more you have the chronic decline in your health status for the heart failure, the more is the mortality. Now, when you look at the renal and the cardiovascular disease are closely interconnected in relation to the type 2 diabetes. These all interconnected between the kidney and also the heart. You have all the hypervolemia, you have the inflammation, the ischemia, the sodium retention, and also you have the neurohormonal activation. So you cannot separate the kidney from the heart. Both of them, they go hand in hand, because the management should be the concept nowadays that you should manage them both together. What about the chronic kidney disease and diabetes? It increased the risk of heart failure. So if you look at the chronic kidney disease, for the 2019 global prevalence is around more than 800 million people. For the heart failure, for the 2017 global prevalence is 64 million people. If you look at the diabetes, you have for the 2017 global prevalence is 476 million. So they are interconnected. So you cannot just say they are not interconnected, because our heterogeneity of our patients, when you come to the hospital, you're going to have patients with the three of them: kidney disease, diabetes, and heart failure. So what is the story of this molecule, the dapagliflozin? Basically, luckily for the last few years, we started with the prevention, and then we started to have the treatment arm for both, for heart failure and also for the CKD. So we started with the DECLARE, TIMI 58, and then we have the DABA heart failure, and then the DABA CKD. And basically, it confirmed that early intervention in patients with type 2 diabetes to prevent cardiorenal complication. For the DABA heart failure, confirming dapagliflozin as the new standard of care for patients with heart failure, reduced ejection fraction with or without diabetes mellitus. And then we have the DABA CKD, the first treatment for patients with CKD with or without type 2 diabetes to improve cardiorenal outcomes and reduce mortality. We will go through this quickly. Basically, the DECLARE 38, the DECLARE TIMI 58 trial design, both arm placebo and dapagliflozin. They looked at the cardiovascular death, MI, and stroke, MACE basically, and also the composite endpoints of hospitalization for heart failure or cardiovascular death. How they looked at it, basically they recruited more than 17,000 patients. The study was evident that patients with type 2 diabetes, they have cardiovascular disease reduction of 40% reduction, and also in regards to the renal protection, it was more obvious for these patients. So when you look at the primary composite endpoints, you have cardiovascular death and heart failure relative reduction of 17%. For renal specific and for the deterioration of the estimated GFR, it was more protective for these patients, and for the new onset albuminuria, it was more protective. And actually, it is not only for the microalbuminuria, it also was for the macroalbuminuria. So, what about the DABA heart failure, the dapagliflozin and prevention of adverse outcome in heart failure trial? So they tested the role of the dapagliflozin in heart failure patients, and as in general, when you look at the heart failure, its effect, as we mentioned, 64 million people worldwide. The 5-year mortality is around 50% for these patients. When you look at the first-line therapy, I think with the recent guidelines in the ESC, it came in 2021. The SGLT2 was mentioned clearly and by name in the guidelines for these patients. So the dapagliflozin, it was the first SGLT2 inhibitor demonstrating a reduction in the death, all-cause death, and heart failure hospitalization in patients with reduced ejection fraction with or without type 2 diabetes. And clearly, according to the latest data, it came up to the guidelines. So how was the study designed? Basically, it was more than 4,744 patients. The two arms of the study was placebo and the dapagliflozin. It was randomized. The safety endpoints for this patient is the dapagliflozin was well tolerated by these patients. Overall, there was a significant reduction in the composite cardiovascular death and worsening of heart failure of 26%. It was clearly also that the risk of both first and recurrent heart failure events was reduced, a reduction in all-cause mortality, and for the heart failure symptom there was improvement, and there was significant reduction in the risk of cardiovascular death, worsening of heart failure as early as 28 days from starting the medicine. So, how is the heart failure burden? So, as we mentioned, again, the heart failure burden, if you compare it across the board between men and women in regards to prostate cancer, lung cancer, colorectal cancer, heart failure comes into account as one of the main, I would say, cause of death for patients. At least if you look at the US data, the 5-year heart failure mortality after diagnosis is 50%. Like 1 out of 2 patients will die from heart failure if untreated properly. What is the mortality improvement? It has been seen that in major cardiovascular diseases and atherosclerosis, but not heart failure or arrhythmia. So we've been doing really good with other cardiovascular diseases. But recently, I think we are coming forward regarding heart failure, and we're trying to improve the outcome for these patients, especially the heart failure patients with all the combination medications available on the market right now. So the heart failure, even with the guideline-directed medical treatment, the dose titration occurs infrequently. I think for the non-cardiologists here might be difficult, but for the cardiologist, is clearly that we are fighting to optimize the medical therapy for these patients. So we are trying to achieve as much as possible the target dosage for these patients with all the subtypes of medication, and we know for a fact it has a role in heart failure patient. So if you look in US at least data, we are just kind of struggling to get the target dose, especially for the beta blocker, especially for the ARNI. If you look at the data from Sweden, UK, and US, I think also the struggle is still there regarding up-titrating the medicine. So the DAPA heart failure, Dapagliflozin and prevention of adverse outcome in heart failure trial, as we mentioned, it looked at the primary endpoint and the secondary endpoint. The primary endpoint by time to first occurrence of any component of composite cardiovascular death or hospitalization or urgent heart failure. As I mentioned in the previous slides, we were trying as much as possible to reduce the amount of hospitalization and also to overcome the wide variety of medicine, and how can we incorporate the Dapagliflozin in the treatment of these patients. So the results was significantly astonishing regarding the reduction of relative risk reduction of cardiovascular death and worsening heart failure on top of standard care by 26%. And it was more pronounced even from starting the medication in 28 days. For the individual component of primary endpoints for worsening heart failure and the cardiovascular death, namely for the heart failure worsening, it was a relative risk reduction of 30%, and for the cardiovascular death was 18% reduction. So clearly there was an evidence, clearly it was evident that the molecule has a role in the treatment of heart failure patients, and the patients been doing better in regards to the hospitalization and cardiovascular death and all-cause mortality. What about secondary composite endpoints? The first heart failure, hospitalization, cardiovascular death, it was a reduction of 25%. And for the total, if you look at the total hospitalization and the cardiovascular death, there was a relative risk reduction of 25%. So you know that these heart failure patients, they are not only a bunch of, name it, we just not like you are combining all the tablets. They have their life. They have their they have to carry on their life. How are you going to incorporate this? Because their symptoms are frequent. Their symptoms sometimes it's severe. Their physical functionality, being able to do their social activities and the quality of life. We are talking here about the quality of life. Would the molecule or the SGLT2 change their ability? Yes. Actually, there was a clinically meaningful improvement in the total of symptom severity and the symptoms frequency. There was also a clinically meaningful improvement in terms of physical functionality, and in terms of social limitation and quality of life, it was improved also. What do we mean? Like, if you look at the being able to dress yourself, being able to go to the shower by yourself, being able to walk 100 yards at least, gardening, household chores, being able to climb, being able to like go for jogging and like for regular walking, it was improved. The only thing regarding the social activity, the intimate and the sexual relationship, there was no significant improvement per se. What about renal function? I mean, we are giving this, it is kind of water pill. Would it also worsen the renal function? If you look clearly regarding this, that these patients haven't deteriorated in regards to their renal function per se in terms of a number of events. So the renal composite is more than 50% sustained decline in eGFR and end-stage renal disease or renal death. So there was some sort of a hint that the drug has an effect in terms of the total number, but the p-value was not significant at the end of the day. What about dapagliflozin in regard to reduce the secondary endpoint of all-cause death? Yes, it was more protective and has relative risk reduction of 17%. What about the new onset type 2 diabetes and heart failure with reduced ejection fraction in this population without the type 2 diabetes? It has some sort of like protective effect for these patients. So even if you started this for patients with non-diabetic, they have a benefit from it. What about the safety results from the DAPA heart failure trial in terms of adverse event? I would say it clearly established the safety profile to be used for patients. A very common question regarding hyperkalemia, if combining with other ARNIs or ACE inhibitors or also mineralocorticoid, clearly that the hyperkalemia event was not significant, so it might not affect as much as the potassium level in these patients. Which is, I mean, at the end of the day, it's an alarming for us as a cardiologist when we see a very high or like increasing potassium level. So the summary for the DAPA heart failure, it is the first and only SGLT2 inhibitor demonstrating a reduction in cardiovascular death, all-cause death, and also a heart failure hospitalization in patients with heart failure with reduced ejection fraction with or without type 2 diabetes. Clearly that the outcome, there was reduction of 26% in terms of cardiovascular death and worsening heart failure, 18% for all-cause cardiovascular death, and for 30% for the worsening heart failure, and 70% for all-cause death. So, and the benefit was consistent in regards to patients with or without diabetes. Patients have been on background heart failure therapy or have been using diuresis, and also baseline ejection fraction regardless of the ejection fraction level, and also regardless of the baseline pro-BNP and regardless of the GFR. When you look to the subgroup analysis, as we mentioned, regarding being started on diabetic or non-diabetic, the dapagliflozin significantly reduced the primary endpoint regardless of the diabetes status and the HbA1c in the no type 2 diabetes group. Also, in regards to the baseline systolic blood pressure, there is a concern regarding starting such medication that might reduce the blood pressure. The effect and the primary endpoint of cardiovascular death and worsening of heart failure, that this is not affected also regardless of the blood pressure level. If you look with other interaction with other medication, because there is a concern regarding also adding the medicine with other medication regarding blood pressure, regarding the diuresis amount. If you look across the board regarding all the subclasses that we use for the heart failure, there is no significant, I would say, interaction. Actually, these patients, they did really well with dapagliflozin with these combinations. In terms of baseline combination, if the baseline therapy combination, also the primary endpoint was consistent regardless of the baseline therapy combination in these patients. What about the diuretic dosage? I received this question repeatedly regarding the diuresis. Would you decrease or increase or like keep it the same? I think here clearly that in terms of 2 weeks, 2 months, 6 months, 12 months, and 18 months, that the majority of patients, they haven't changed their diuretic dosage. So this is kind of reassurance. Now, you have to follow up the patient and you have to make sure about the volume status for these patients in the clinic, because some of the patients you might reduce the dose of the diuresis, but the majority you might not need to change your diuresis dosage. What about the dapagliflozin benefit? Also is consistent regardless of the background of scopotriol and valsartan usage, with similar adverse event between the two groups. So also with the new introduction of the ARNI to the management of heart failure, the benefit was consistent also when you add dapagliflozin on the scopetrol and valsartan. This is the effect also consistent in regards to the range of ejection fraction, because I get a lot of questions regarding shall we start it for an ejection fraction of 15% or 20% or like 30%. I think the primary composite outcome and the individual component of an all-cause death is not different between the level of the ejection fraction in these patients. What about the benefit if it's consistent across the spectrum of eGFR, regardless of your GFR? Also, the benefit is there in regards to starting the dapagliflozin. What about the depth and breadth of the cardiorenal benefit? I think it's regarding the DABA heart failure and the DABA CKD. As we mentioned earlier, to look at the DABA CKD result, it's confirmed that it is the first and the only SGLT2 inhibitor renal outcome trial in patients with CKD and with or without type 2 diabetes. The effect is pronounced. I will go through it. Basically, the CKD patients, they included more than 4,000 patients. The two arms received the placebo and also the DABA 10 milligram. There was a 40% relative reduction in regards to the composite outcome of the sustained more than 50% eGFR decline with end-stage renal kidney disease or renal death. There was also 29% relative reduction in cardiovascular death and hospitalization for heart failure, and 31% relative risk reduction in all-cause mortality. This trial was stopped, and to stop the trial because of the early overwhelming efficacy data that showed with starting the dapagliflozin. So the result was consistent in patients with and without type 2 diabetes. That was the first renal outcome study to show robust benefit on all-cause mortality, and as I mentioned, it was in terms of the safety, the dapagliflozin was the well-tolerated, keeping with its established safety profile. So these are the studies that we came across regarding the dapagliflozin. I think the DABA-CARE here, we are awaiting other studies to come along, like the DABA-DELIVER, and hopefully by the end of this year. We have also the acute heart failure, DABA acute heart failure by 2023, and also for the acute MI, DABA MI, it will come by 2023. So the recruitment is still there. We're going to have like interesting data coming up for these patients, and hopefully to improve the our care to our patient. So how are we going to implement dapagliflozin in the clinical practice for the treatment of heart failure with reduced ejection fraction? This is the guidelines. The guidelines now is shown clearly from the ESC in 2021, using the ACE and ARNI, using the beta blocker, using the mineralocorticoid, and also using the SGLT2 and the usage of the loop diuretic for fluid retention. It is a class 1A that the dapagliflozin or empagliflozin are recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. In the 2021, we have the ACC experts consensus also include dapagliflozin as a component of first-line treatment for patients with heart failure with reduced ejection fraction. ACE, ARB, and ARNI, and clearly now the ARNI is preferred. You start beta blocker and you start the diuresis, and then you can start the mineralocorticoid, SGLT2, and also diuretic agent, plus the hydralazine and isosorbide, and the ivabradine. But it's clearly mentioned that the ARNI, beta blocker, MRAs, and the SGLT2 inhibitor are the first-line medication for all patients with heart failure with reduced ejection fraction. So McMurray, and the recommendation recently in the circulation 2021, I think step 1, and the rationale for this, and the first line therapy for heart failure patient to use the beta blocker plus the SGLT2. This is a proposed way of starting the treatment. And step 2, within 1 or 2 weeks of step 1, you can add the ARNI for these patients, and then you have a step 3. Within 1 or 2 weeks, you can add the mineralocorticoid. So by 4 weeks, the patient will be on the 4 main classes for the treatment of heart failure. What is the limitation for traditional heart failure with reduced ejection fraction therapy sequencing? Because a lot of cardiologists now, they start with the ACE, ARB, and then they start beta blocker, and then the mineralocorticoid, and then they start the ARNI, and then they end up with SGLT2. So there is some sort of a delay in starting the treatment. A lot of the physicians, they start starting to double the doses, and they don't get the benefit of the SGLT2 from the beginning of diagnosing the patient with heart failure. So the consideration of use of dapagliflozin use in patients with heart failure, I think the main thing here is counseling the patient. Get your endocrinologist also on board, especially if the patient is a diabetic. Watch for volume depletion and orthostatic hypotension on these patients. Watch for symptoms of DKA, and also get the patient to know about the hygienic genital and perineal hygiene. Make sure about the adjustment of concomitant medication. Patient on loop diuretics may be at increased risk of volume depletion, so you have to review these patients. Make sure that they don't over-diurese, and also the increased risk of hypoglycemia when the dapagliflozin is combined with insulin. This should be in cooperation with your endocrinologist. This is my last slide. It's regarding the management of heart failure with a reduced ejection fraction. Clearly mentioned in the EAC guidelines, using the ACE and ARNI, beta blocker, mineralocorticoid, and SGLT2 inhibitors. I think nowadays a lot of cardiologists, they are more prone to start the SGLT2 from the beginning for a treatment of heart failure, and it is. I mean, at the end of the day, you want the benefit of the drug and to protect the kidney at the end of the day, and also to make sure that the patient might not get the side effect of other medicine from increasing the dose, especially hypertension. We struggle with these patients regarding their blood pressure management at some point in their treatment during the course of heart failure management. Thank you, and the floor is open for any question. Right, right.
But I think, to me, I'd like to hear your opinion, and maybe there. Now, if you have used the same medication, DAPA is a very effective drug, in reducing the glucose at least. If you are using the same drug in a patient with very low carbohydrate, okay, or shall we say? So very low carbohydrate, less than 50 grams. I expect the result will be much better, okay? Yeah. And stop using insulin, because insulin by itself is a hazardous, and can cause hypertension, and can cause renal failure, and can cause also the cardiac. So in a way, I expect the result will be much better, okay? In case the final result. I don't know what's your view.
I totally agree with you. I mean, I think it's mentioned even in this comprehensive, if you look at this slide, regarding even the having the dietitian with you on board, because especially for diabetic patient, you want to control their sugar. So having a multidisciplinary approach for this patient is the mainstay. It is recommended, and having a good communication with your endocrinologist, it's a must. It's a must. Thank you.